Wow, there's good energy in the room. Very erudite questions and very insightful. And I really loved that healthcare is personal, very personal. The next section, we really dive in deep into specific country context. And I'd love to invite my fellow panelists, Dr. Elizabeth Onyango. And Dr. Elizabeth Onyango is the head of the section on noncommunicable diseases and prevention at the Ministry of Health in Kenya. She's also a maxillofacial surgeon, a public health specialist with over 23 years of experience working in both public service at a subnational and national level. I'd also love to welcome Dr. Elizabeth Wangia, who's the Director of Health Financing at the Ministry of Health in Kenya. She's also a medical doctor by training, a health specialist with over 10 years of experience in health policy development, monitoring, evaluation. She's been involved in development of the Kenya Health Sector Strategic Plan 2018-2023 and even beyond to the next one. She's also been involved in development outside Kenya in development and costing of health information systems in places like the Kingdom of Eswatini. And I'd love to also invite online I'd love to invite Stephanie Kotsala, who's the CEO and founder of Penda Health. Penda Health is the third largest outpatient private healthcare company in Kenya. Their high-tech solution for primary care combines 19 tech-enabled medical centers, home-based care, drug delivery, and a robust telemedicine service to provide quality treatment for patients with convenience and affordability. Welcome all, and such a pleasure. And to the audience, thank you so much. It's a pleasure to sit with you and to discuss. I am going to do something that the amazing people who've put this show together and this whole presentation will get at me at. Later on, I promise to drink 2 extra cups of tea for every infraction I'm about to make. And I will do a lot of discussion here and shift to have more time for questions with the audience, just to make sure that I think there's good energy and amazing comments and insights and a deep sense of experience amongst all the people here. And the ultimate goal is to help shape what the next decade plus of addressing NCDs in our world, in our region, in our countries at an individual level to improve outcomes. So we'll take a quick dive into Kenya, and I will wear my other hat, which is I represent, or I will represent to speak to some of the legacy systems of training and care development, sort of building infrastructure at a tertiary facility, which I still work heavily to do. And I'll be the counterfactual to say, hey, some of the things that we've done in the past are still very valuable to say we do need a subspecialty development. We do need some of this tertiary quaternary facility. And certainly from the primary care standpoint, how do we get that to intersect? So Kenya, double burden of disease, triple burden, if I may argue. There's injury, there's infectious diseases, COVID straddles even onto noncommunicable diseases that are growing. And projections are that we will have an almost seemingly insurmountable burden of noncommunicable disease. We talk about hypertension, diabetes, cardiometabolic disease, renal failure, strokes. I might be rattling off the things that are passionate to me as a cardiologist, but also there are challenges in how this takes care. There are other things that are still pervasive, from malaria to rheumatic heart disease to typhoid or to diarrheal diseases. Maybe my first question to Dr. Onyango is, what is the current state of where NCDs and non-communicable diseases and infectious diseases, and how does this all intersect?
Good morning, everyone, and thank you, Titus, for that wonderful introduction, introducing us, Kenyans, as part of us. We are happy and delighted to be part of the forum and panelists. Now, concerning Kenya, I don't know how many of us have been to Kenya, but Kenya is found on the east coast of Africa. We have a population of around 56 million people. And as you've been told, we're experiencing a growing burden of non-communicable diseases. At the same time, we are still addressing HIV, TB, malaria, and other non-infectious conditions. Injuries and violence also coming up to be a growing concern. So as per 2022, if I can give statistics, non-communicable diseases were accounting for approximately 41% of mortalities. And this has come up from 27% in 2014. So within 8 years, you can see the increase. And it's projected to contribute to almost half of mortalities by 2030. And we are not far from 2030. So for us, this is really a growing concern. I can say there are multiple causes for this. But again, if we come to NCDs specifically, we realize that 4 conditions are contributing to more than half of these mortalities. So among the NCDs, these are CVDs, the cardiovascular diseases, diabetes, cancers, and COPDs, the chronic obstructive pulmonary diseases. And we, as a country, we are coming up or implementing policies that are going to address that. So, Doc, I can.
Yes.
Yeah.
Yes, please. Okay. We'll come back and talk about some of these policies and what these policies are. I'll pull in Dr. Wangia and say, you know, we've just talked about cardiovascular disease. We've talked about diabetes. We've talked about COPD, pulmonary disease. We've talked about, there's renal disease. All of these diseases are increasing, and we are doing more work from a preventive footing to screen and find more people with these diseases. How does this fit into the budget, and what's the budget, and how do things play out?
Thank you so much, Titus, and also to the organizers for giving us this opportunity to share with you the country experience. Indeed, Kenya is undergoing a triple burden of disease. The non-communicable diseases are, of course, on the rise, yet we still have a high burden of, the communicable diseases, malaria, TB, HIV, diarrheal diseases, pneumonia, and the like. When just looking at the financing overview landscape in Kenya, we have a mixed form of financing. So we have finances from the taxes, we have finances from the donors, social health insurance, and also out of pocket. Currently, we are undergoing what we call health system reforms, because we have acknowledged that, one, having moved from a low income country to a lower middle income country, the donor funding is coming down. The other thing that we know also is that we have a limited fiscal space, given that we have a high debt burden. Out of 10 shillings that we collect as a country, 7 shillings goes into debt repayments, followed by priorities around the military, then the personnel emoluments. Then now other sectors can start seeing how they can justify for resources. So of course we acknowledge that in as much as we would want to prioritize health, the resources are limited, and therefore actually this forum is quite key, because we really need to be innovative. As a country, we spend, the last time we did our national health accounts, we were at around 4 billion per annum in terms of the total health expenditure. That means resources from all areas, whether it's donors, out of pocket, insurance, and the like. but we are not seeing much improvement in our health outcomes. When you look at our maternal indicators, which are usually the key indicators, they are really doing poorly. We have increased access to maternal care, but when you look at the mortality, we are still having challenges. But also the good thing is that we have had quite significant improvement when it comes to access to data around utilization, especially when it comes to non-communicable diseases. And this has really helped us as we prioritize, because currently we are implementing social health insurance. For the first time, we want to target 85% of the population being on social health insurance, which is both contributory and also government funded. And in this, we had to see how do we bring all these programs together. And one thing is, given that we had a lot of data around renal conditions, cardiac conditions, they have actually taken a significant budget. Initially, within the social health insurance, we have a component that is publicly financed. We were expecting a significant amount of resources so that we can get into, a lot of preventive interventions. But then because of all this limitation in resources, we were not able to get adequate resources. But the whole plan is to be able to screen early at primary level and even at community level and manage early, because screening without management is it really is not really productive. But then one thing that I would like to say as a gain as a country is that for us, over the last 1 year, we have been able to pay our community health promoters. We actually have 107,000 community health promoters, previously called volunteers, but since we are remunerating them a bit, we have given them, they all have phones. We have what we call the electronic community health information system, where they collect this information on a real-time basis. And even right now, I can just check on the dashboard and see how many households have been visited. Currently, we are registering people for social health insurance. We are using them. So they are going to the communities. Each community health promoters has 100 households. So they go to their communities and are actually finding out whether they are registered or not, and they're able to convince them. We gave them a small summary of the benefits package, just to something that they can communicate to the people at community level. Tell them if you take up this social health insurance, you are able to get this and that benefit. They are able to give preventive and promotive messaging. As it is right now, we have not gone into them doing the real interventions. There have been a lot of issues around that, but they're able to give like painkillers, deworming medicines, but not really going into doing the real interventions. Training has been also ongoing. We have community modules that are integrated, and at the end of the day, a lot of partners really used to invest in these community interventions, which have been taken up currently by government. And therefore, the question as we discuss with the partners is, how do we redirect your resources? The ones that you're initially investing in a fragmented way in community health interventions to other interventions. So we know last year there was what we call the Lusaka Declaration, where we say that we want to come up with one plan, one budget, one monitoring. And of course, the issues around governance still exist on how, even for the financials, their concern is, if we put this money in one pot, are we sure that it will do the right thing? But now we are sure that they have freed up their resources around community health interventions. Therefore, how do we redirect those resources to address other interventions, and specifically, in this case, screening and early interventions?
Wonderful. This is actually really highlights the importance of having everyone come together and start thinking collectively around what the analogies, the elephant, someone's touching the ears, the tasks and all seeing different sides of the same problem and coming together to say, oh yeah, this is true. An elephant or a warthog or some other creature that's out there. We'll talk and perhaps loop in Stephanie now to talk a little bit more and from the vantage point of the private sector and say she's been working with her team closely to try and improve access through multiple clinics and leveraging digital technology and resources to improve efficiency and quality of care. Stephanie, what innovations have you been able to bundle together? Because there's so many moving parts. If you're thinking from the private sector, you don't have the resources of ministry and government, but within private sector, you have capacity to marshal some of this resources. I think we don't have her connected, but we'll come back to it because in the follow-up to this session, we'll still have lots of conversation on the finance side. A quick follow-up then on the policy front is there are digital regulations, there's we talked about social health financing. All of these policies need to come together to support delivery of healthcare. Maybe Dr. Nyango, if you could tell us what policies are recently in the pipeline, what policies are coming soon, or what are things that we should anticipate in terms of improving the environment for delivery of healthcare and NCDs.
Thank you, Dr. Ngeno, for that. As a country, we've mentioned that we are experiencing a growing burden of NCDs. And to help us address this growing burden, we as a country, we have come up with a NCD strategic plan. This is actually our second strategic plan that we're implementing, running from 2022 to 2027. It's a 5-year strategic plan. And this strategic plan is definitely anchored on the Kenya health policy for 2014 to 2030, which is also anchored to the Constitution of Kenya, which provides that every Kenyan or every person in Kenya has a right to the highest attainable standard of health that the country can afford to give. And in our health policy, we have mainly 6 policy objectives, out of which 5 directly address the non-communicable diseases. So just allow me to highlight some of the focus for our NCD strategic plan for the next for the 5 years. What we are focusing on, we are focusing on strengthening leadership and governance and multi-sectoral collaboration coordination for NCDs, because we understand that most of the risk factors and determinants of NCDs are not limited within the perimeter of the health sector. So we need to work with other stakeholders. We need to work with the private sector, as it has been mentioned, the academia, the education, agriculture, anyone else who has a role to play in addressing the risk factors and the determinants of NCD. Then the second pillar for our NCD strategic plan is now to address the modifiable risk factors for NCDs. And the third pillar is strengthening the health system so that it's able to provide quality and accessible care for managing NCDs. And then we have the advocacy, social mobilization, communication, and last is surveillance, monitoring, evaluation, and learning as the our 5 main pillars. So what have we done as a country under enhancing multi-sectoral collaboration? We have established the NCD inter-sectoral coordination committee, and this committee is headed by the Director General for Health as the chair, and we have been membership drawn from many organizations, and I have to emphasize, including people with lived experience of of NCD. They actually give us their voices and they give meaning to this coordination committee because they always say there's no health without us. They have forgotten the slogan, but they keep on reminding that they are part of that initiative. And this we have replicated to the subnational level. By the subnational level, we call them the technical working groups, NCD technical working groups, which also has a broad-based membership depending on the interest. But let me say that they have clear terms of references, both the national one and the subnational one. And in the national one, we've also ensured that the subnational are represented so that we are in a way connected. I forgot to mention that in Kenya, we have a devolved system of government. We have the national and the county government. And so we have to work closely because most of the service delivery happens at the lower level. Now, when we go to, allow me to concentrate on the third pillar, and that is on strengthening the health system so that it's robust enough, it's able to respond to the NCD issues. And the first one, as mentioned by my colleague, Dr. Wangia, we want to strengthen the primary healthcare component. That is a provision of NCD services from community level and the lower levels where patients first interact with the health services. She's mentioned about the community health promoters. We have over 100,000 of them providing care to these 56 billion Kenyans. So ideally, one community health promoter is able to take care of 500 people. So if you do the maths, it translates to around 50 million people being taken care of. And the government of Kenya is providing around $40 per month for each of these community health promoters. So the national government is giving half of that, and the county, the subnational government is providing the rest of that. And for NCDs, these community healthcare promoters have been equipped with kits. They've been given glucometers, they've been given BP machines, they're able to screen for diabetes, they're able to screen for hypertension at the community level. And they have the smartphones. So as they screen, they're able to enter data, get details of the clients. And this is transmitted in, it's called the ICHIS. ICHIS stands for Electronic Community Health Information System. So actually our president on a daily basis gets information on the screening or whatever services that has been provided at community level. He gets it on a dashboard. And we're really glad that even as NCDs, we are pioneering this. Then another thing is to ensure that the NCD agenda fits NCDs actually fits within the UHC agenda, which my colleague has also mentioned. And how is this? We have identified the essential interventions that need to be included in the essential benefits package. We have the three funds, the three main funds that we are rolling out as a country. It was rolled out from 1st of October. And NCDs, how are they going to benefit? At primary healthcare level, we have the primary healthcare fund. Dr. Wangia will maybe highlight later. And so anyone accessing services at those levels should be able to be covered under that fund. Then we have the SHIF. She'll explain what SHIF is. Allow me not to go to those details. And then we have the emergency, chronic, and critical illness.
Well, I think it's good, especially we'll take a deeper dive into financing strategies and approaches. Maybe because I want to make sure we capture some questions from the audience. One more question, and certainly invite. I'll walk the mic over to you if you have a question. Is for context, the administrative structure for healthcare got evolved now maybe 8-10 years ago. from a national central government to individual counties. In the US, the analogy I use is expansion. Now, thinking about it from the lens of expansion of Medicaid, that not all counties are embracing the policies in the same way, and each county is directing its individual healthcare agenda, but there's a national government that's steering it. And maybe as we think about how to implementation or engagement or integration across the different silos that we were talking about earlier, is what are the mechanisms for bringing together some of these policies that perhaps Dr. Wangei could speak to? How do you reconcile what the counties are saying and what the national government is saying? Is there a time when you're on different, you're looking at things from opposite ends of the world, and how do you bridge the gap?
So thank you very much. Indeed, you correctly put it that Kenya has a devolved setting. We have 47 subnational units, which are called counties. Each of these counties is independent, yet dependent on each other. The roles between the national government and the subnational government are very clear according to the Constitution, with the national government's main role being around policy development, capacity building, and management of the referral facilities. We have around 5 referral facilities. Then the county's mandate is mainly around service delivery. Over time, in the past, there have been a bit of conflicts as to who should do what, but then you realize that in the health sector, there is no hard stop where the national government, the national government's role starts and stops at a particular area, and the county government picks up. As the national government has indicated, our main role is around policy and legislation. So in the past, in the past, we have the Kenya Health Policy, which guides the counties. We have the national level strategic plan, which also guides the counties. In the last 1 year, to be specific, actually, it was October last year, we passed 4 critical legislations. So we had the Digital Health Act that aims at ensuring that that all health data is managed in one central area. There is data portability, there is interoperability within the systems, and of course, bearing in mind the data protection. Right now in Kenya, issues to do with data protection are very, very high. Just yesterday, there was a big issue around some migration of data, and everyone asking whether they were consulted before their data was migrated. Then we have the Primary Healthcare Act. So the Primary Healthcare Act's aim is to actually reorganize the entire health system with a focus on primary healthcare, bringing in community health promoters, and we are currently implementing what we call primary care networks, where we have a hub and a spoke and several spokes which are meant to work together. And even in our current financing model, we are financing according to the primary care network, so that we ensure that the networks actually communicate with each other. Then we have the Social Health Insurance Act that established what we call the Social Health Authority that will manage social health insurance for the country. Then the final act is around the Facility Improvement Financing Act. At facility level, the counties, with devolution, there were some, I would say, retrogressive laws that demanded of the counties to submit the resources they have collected to the general pot of the county. And many a times this money didn't used to go back to the health sector. But with the Facility Improvement Financing Act, any collection done at facility level remains at facility level, and they are given the autonomy to decide and manage those resources, because you can collect, but you don't have the autonomy to utilize. And therefore, these are the foundations where the counties actually pick up and implement, because at the end of the day, they are the implementers of whatever policies and strategies.
I laugh because you've been very diplomatic around the discussions that happen between reallocation of resources, and which is good. I'd love to invite anyone with any questions around, are there key areas, gee, how did 4 billion manage to pay community health workers and build facilities? Oh, no.
Hi, I'm Stephanie Weiland, and I've been involved in this network for a while. Currently an independent consultant working primarily with Solid Africa in Rwanda. My question about there's so much going on in Kenya's policies, and it's really exciting. I'm very curious, how much a role, if any, have studied like economic evaluations of cost effectiveness or cost benefit played at the ministerial level? Have you all discuss these kinds of things? Have these played a role in the decision making, in the strategies, or any of the policies to your knowledge? I'd love to understand that.
Should I?
Maybe we, yeah.
Thanks. My name is Joy. Just congratulations on your work with the community health promoters, and I love the fact that you're engaging young people there. That's absolutely wonderful. And also congratulate you on increasing the rate of breast milk, for breastfeeding for the first 6 months. You're one of the few countries on the continent that are over 60%. So I hope you'll be able to sustain that and improve it. I just have a question. Have you considered introducing syntax, or have you already introduced it, particularly for sugar, perhaps in a way to supplement the community health insurance? And I also want to find out how you are improving the nutrition in collaboration with the Ministry of Agriculture, because I know you've got huge investments in agriculture that are being funded by development partners. You talked about the loans you are repaying. Some of them are for agriculture. So what is the nutrition sort of agreement between the Ministry of Health and Agriculture?
And as
Hi, my name is Louise still. No, just a reflection on your progress in recognizing the value of your health promoter network and the people who do this incredibly important work. It's very sad that we hear that indeed in many countries, community health workers are unpaid or hardly paid, untrained, etc. There's no investment at that level. So I just want to hear, and I understand even from my own country, home country, Denmark, where the care sector is being cut again and again. And then there's a big debate right now about the value of care. The fact that that piece of the equation, because we can't really measure the value of education, of health care, when it's given by humans, it gets lost in translation. And, economic reports can present great progress. We cut here, we cut there, and it's all good, but it doesn't cost anything on paper. So you, as being responsible for health finance, I find it really fascinating that you've managed to make this progress, and congratulations to both of you. It's really beautiful to hear of what you're doing, but just wanted to hear your thoughts on that. Like, how do you argue for the value of care and actually investing in care?
maybe we'll split the questions and then pick some. You want to go first? Okay, yeah, sorry.
Hello, my name is Ndasoa Chitule. I'm coming from Malawi. It's exciting to hear what's going on in Kenya. Malawi is also going through some similar reforms. We haven't gained that much traction yet, but direction is similar. My question is back to innovation and health. I think the simpler version of the cost-effective analysis question. You mentioned that the community health promoters are given phones, they're using IKIS, you have a database and all of that. Is this, probably maybe Penda would have explained that, but I think, is this being supported by government? Is this equipment being provided by government? Is this being done by NGOs or other donors? How are you sustaining or financing that aspect of digital innovation?
Okay. Why don't you start, Dr. Nyangu? Yeah. Yes.
Okay. I'll attempt to respond to some of the questions raised. Maybe I start from the last one. How are we funding this? This being funded by the government wholly? Yes, is the government putting the budget for that? And is the one that is paying the CHP, is the one that is buying the equipment, is the one that will replenish even the supplies. We are transitioning, it's called what? Journey to self-reliance. That's where we are now. There's another question on economic evaluation. Can start by saying that NCD, I mentioned we have a strategic plan, but the financial gap is quite huge. And sometimes when you want to go to the Ministry of Finance or the Treasury to ask for money, the language they understand is returns on investment. There's the ISAs, there's the quality of life gained and the disability adjusted life years averted and the rest. We attempted to do some of those investment cases for CVD, and we demonstrated that for every shilling invested, there'll be a saving of 2 shillings. So we attempted to convince them. So it's still an advocacy work ongoing, but I believe there's still more that needs to be done in terms of economic evaluation. But at what point do we balance the returns on investment and equity? Yeah, because we still have those that the return may not be there, but services have to reach each and every person, the vulnerable, the marginalized, and the poor. Yeah, so for me, that's what I'll leave it at. We have to balance the two. And the other thing about Ministry of Agriculture, they form part of our NCD ICC committee. We work closely with them. And right now we're in the process of developing policies that will address, what is it called? Just to improve the food environment so that people are able to adopt healthy policies, healthy diets, and healthy lifestyle. So we work closely with them. They're part of our NCD ICC. I don't know if they said.
Okay. Thank you. I'll just add on to the question around economic evaluation also. The whole of this year, since November up to 2 or 3 weeks ago, we were in the process of developing the essential benefit package for the social health insurance. And this time we really used a lot of data. Because the law had provided that we need to develop a benefit package that is explicit and that is driven by data. And in fact, the law actually provides for the establishment of a health benefits and tariffs advisory panel that will be reviewing the benefits every 2 years and advising the government. This is an independent body which will be actually stationed in a university, because we acknowledge that this information, such kind of research, cannot be done by the ministry. We are very busy doing many other things. No offense. I mean, research is, research is another component, but
I almost fell off my chair.
yes. So we let the respective institution do their core mandate, and therefore this will be based actually in a university. But as we did develop the benefit package, apart from starting from the essential package for health, what is in it, the whole universe of interventions that we consider as essential, we went down to prioritization. As we did the prioritization, we were even looking at, when you look at there's what we call the WHO DCP 3 criteria. It gives even the ISAs per intervention. So for those interventions that had ISAs that were significant, we actually considered them as priority, because within this DCP 3 criteria, it outlines the priority interventions for low-middle income countries, that if low-middle income countries invest in those priorities, then they're actually on the journey towards attainment of UHC. So we actually used that information to narrow down to interventions. Unfortunately, not all interventions have ISAs. And therefore, we are hoping that with this benefit package advisory panel, they'll be able to do some of those studies and build to the database of, this database. There was a question around sin taxes. It's usually, I don't know, a difficult thing to really narrow down and say that, sin taxes can. I know there are countries that have really worked on sin taxes, but the flip side of it is, if, for instance, you base yourself on sin taxes, when it comes to overall government allocation, the Treasury are likely to say that you have already your sin taxes, therefore we don't need to give you the resources. And therefore, at the end of the day, you may never know whether you'll collect enough through the sin taxes. So it's better off for all this, even if they're sin taxes, they shouldn't be earmarked to health. We have tobacco, we have alcohol, we have not done sin taxes on sugary sweetened beverages, but those other ones are there, but they go to the greater pool. They are not earmarked to health. And therefore, we are able to get our, if we justify for our resources, we are assured of our resources instead of depending on whatever will be collected on sin taxes. The thing about community health promoters that we are excited about is that we have the highest political will. It's very difficult to buy political will. The president talks about the community health promoters at least on a weekly basis. Yeah, on a weekly basis. And therefore, he has even committed to, there was that commitment to replenishing the supplies for the next 5 years. So there's a contract, and we're working closely with the private sector. We have our greatest telecom, where even when you look at the mobile phones, they're actually geo-locked. If you try using that phone in an area that's not within your community health promoter area, it won't work. So that is the innovation that the private sector has actually brought in to support us. Then I think that will be it. So the final question was around looking at health in terms of just looking at the value of care when you're looking at health. This is something that is in discussion. Just trying to see how health can be brought about as an economic booster instead of a spender, more or less. And because we thought that even after COVID, people will acknowledge that you need to be healthy to build the economy. So those are some of the discussions and studies that need to be done to justify that this investing in health is actually leads to economic transformation.
I am delighted to hear that there's hope, that there's the need for there's job security in researchers like myself, that there's but really importantly, to wrap up, I know I think one of these things is flashing at me and saying we have 2 minutes. So maybe just to summarize, and I'm not sure we'll be able to capture all of it, but important things that we've talked about underlying sort of the road to sustainability, having data-driven decisions and agendas and policies, and having policies that are multi-sectoral, cutting across not just the Ministry of Finance, which is where we think a lot about, but also think about how it intersects to the Ministry of Agriculture, how we intersect to the Ministry of Information Technology, digital tools, data protection, and leveraging information systems within among community health workers, protecting the interests and well-being of community health promoters, and even having a lot. I mean, if there's an opportunity for political capital, I shy away from politics, but I like what politics can do when it does good. And I'd most importantly want to thank our panelists and the audience for participating and joining in this discussion. We will take a deeper dive into part B and after a short break, but certainly thank you so much.